Good morning, all. I don't know how you're there. Okay, good. So you have to guide me as to where I stopped in the last class. I think acute pancreatitis. Did we finish all this? Mechanism, yes. Mechanism is over. Type of injury, yes. Systemic effect, yes. I think it's over. This slide is over. Yeah, I think it's over. This slide is also over. Causes, yes, we discussed this causes. SIRS, we discussed. Clinical presentation, I think, yes. We'll take off from clinical presentation. I think the initial part of the clinical presentation we had done. Okay, so yeah. So basically, when we talk about the clinical presentation in acute pancreatitis, there are, since you have seen the pathology part, how it happens pathophysiologically and in terms of the pathology within the gland, there are two things. One is there is edema, and second thing is there is necrosis that happens. So you have basically a spectrum of presentation. Those who have edema basically have typical pain abdomen and all those things which are associated with pancreatitis, but they do not really go into any systemic related problems. That means they do not have any organ dysfunction, what we call as multiple organ dysfunction syndrome. That is not something that happens. And they do not go into multi-organ failure. Okay, so we have given you the outline of the spectrum of presentation that we can have. Right. So one of the most typical features about pancreatitis is the type of pain they get. Number one, the pain is located in the epigastrium, or sometimes the patient will just say the pain is somewhere in the upper quadrant. Or very rarely, when it's a little more severe variety, patient may complain of diffuse pain over the whole abdomen. But classically, the pain is in the epigastrium. There is typically also radiation to the back that most patients complain. That means about 50% of the patient will complain of the pain in the epigastrium, which is radiating to the back. And mind you, the pain is quite severe. Okay. Some patients, again, typically what we have seen in acute pancreatitis and what we typically say as pain which is associated with acute pancreatitis is when they sit up in the bed and lean or bend forward, the pain appears to come down. So most of such patients will prefer to sit on the bed and bend forward, because by doing this, the pain gets relieved. The mechanism by which this apparently happens is the pancreas falls a little forward from the retropancreatic peripancreatic nerves which are there in the retroperitoneum. So once they sit and bend forward, the pancreas leans away from the posterior part where you have the pancreatic nerves, and apparently that is what leads to relief of pain. Now this is only a theory, we still do not know what really causes pain. The other reason why patients have pain, and especially so in the case of chronic pancreatitis, is because of what you call as intraductal hypertension. So when we talk about theory of pain in pancreatitis, one is because of irritation of the peripancreatic and the retropancreatic nerve endings. And that is typically seen in acute pancreatitis. And in the case of chronic pancreatitis, perhaps it is because of the intraductal hypertension. Now, these two things you need to remember. Okay. Now, the pain is quite sudden in its onset. And for that reason, the other variety of pain that you get in the epigastrium, which is quite sudden in onset and quite severe and radiates to the back, is typically what you see in the case of a perforated peptic ulcer. Okay, having said perforated peptic ulcer, patient can also have pain which can mimic a chronic peptic ulcer without perforation. In the chronic peptic ulcer, which is located posteriorly, the typical history the patient gives you is pain in the epigastrium, which radiates to the back. And that's exactly what you see here also. So because of radiation to the back, it can mimic a case of acute pancreatitis. So there are two pain in the epigastrium which you need to remember, which can radiate to the back, is number one, acute pancreatitis, or for that matter, even chronic pancreatitis, you can get the same picture. So acute pancreatitis, chronic pancreatitis, and third thing is a chronic peptic ulcer which is located in the posterior part of the duodenum. These are the three varieties of pain where the pain can arise in the epigastrium and radiate to the back. Then, like I said, the pain sometimes can be just in the epigastrium or sometimes can be the upper quadrant. And when it's more towards the right, it can mimic biliary colic or a case of acute cholecystitis. The pain sometimes, apart from radiating to the back, sometimes can radiate to the chest also. And when it radiates to the chest, many a times, especially if the patient is a little elderly gentleman, we can mistakenly start thinking that the patient actually may be having myocardial infarction. And such patients, many a times we have had when they have gone first to the cardiology or to the medicine department, and after admitting them and doing an ECG, they find that the ECG is normal, and they have been referred to surgery, and in surgery we have discovered that they actually are a case of acute pancreatitis. So myocardial infarction because of radiation to the chest. The pain sometimes in acute pancreatitis can also radiate to the chest, and therefore it can mimic myocardial infarction. Having said that, in the initial stages, the day one, probably the patient may not have pain which is radiating to the chest. But usually after a day or two, when the patient has pleural effusion, that is the time when the patient can actually complain of chest pain or pain which is radiating to the chest. And in those cases, typically the diagnosis sometimes can be one of myocardial infarction. And for the same reason, pain in the chest, common reasons are number one, myocardial infarction, which is quite dramatic, as acute pancreatitis is. Then you can also mistake that pain for a case of pneumonia or pleuritic pain. Okay, so in short, what we can say is acute pancreatitis can mimic most of the various causes of acute abdomen that we see and should seldom be discounted in differential diagnosis. That means many times, unless you have basically based on pain only, we cannot establish a diagnosis of acute pancreatitis, because many other conditions patient either will have nausea or have vomiting or retching or hiccups, and many a times you can find a combination of all four happening, or out of all these four, at least one or two of these symptoms like nausea and vomiting may be there, and retching and hiccups may or may not be there. But classically, yes, you need to mention that the patient can have nausea, persistent vomiting, retching and hiccups. And more often than not, patient will manifest some degree of shock. And this is typically seen in those patients who have a much severe variety of acute pancreatitis. So the features of shock will be number one, decrease in the BP, tachycardia, tachypnea, cold, clammy extremities, and of course decreased urine output. When you do the abdominal examination, these are the following things that you will find. Mostly you will find that there's decreased bowel sounds, the peristaltic activity has come down. There is some degree of abdominal distension because of accumulation of the fluid, the reactive fluid that leads to formation of ascites. Very typically, you will find that the patient will be having upper abdominal tenderness and guarding, and sometimes the whole abdomen can be manifesting this guarding and rigidity. But typically, if you look at it very carefully, the patient will tell you that the maximum tenderness is usually there in the epigastrium or in the upper abdomen. And this is typically because of the inflamed underlying pancreas that is there. Patients sometimes can complain of breathlessness, and this breathlessness is usually because either of ARDS, or it could be because of either ARDS, or there could be pleural effusion. So either of these two can be the cause for breathlessness in patients. Patients also can have decreased breath sounds, and that is typically because of pleural effusion. Because once there is pleural effusion, when you auscultate, the breath sounds which are there on that side get muffled, and that's the reason why the breath sounds on that side are decreased. And of course, if you percuss, you will find the stony dullness is what you get on percussion. On palpation, sometimes when the tenderness is not too much and the guarding is not much, you sometimes can feel a vague mass in the epigastric area. But mind you, this mass is not something that is very well palpable. And usually this is because of peripancreatic fluid collection, edema of the pancreas. So because of this, there is something like an inflammatory mass that is there in the peripancreatic region, and this sometimes can be palpated in those patients where the pain abdomen and guarding is not profound. A patient can have jaundice sometimes, especially so because in some, as we have seen in the causes, one of the leading causes, especially in the West, is gallstone-induced pancreatitis. So you must always look for the possibility of jaundice. So whenever jaundice is there, in our Indian scenario, if jaundice is there in a patient whose enzyme levels of amylase and lipase are 3 times high, the likely causes are number one, gallstone-induced pancreatitis, and the second important reason, which is quite exclusive to third world country like India, is presence of ascaris, worms in the biliary system. And there are 2 important signs which I want you to remember. Is number one is Cullen sign, and the number 2 thing is what is called as Gray Turner sign. These are basically collection of hemorrhagic fluid. Once you see Cullen sign and Gray Turner sign, that usually means that you are dealing with a case of necrotizing pancreatitis, and the prognosis in such patients is much worse compared to those type of patients where they are having an edematous pancreatitis. So presence of Cullen sign and Gray Turner sign is considered as a red flag sign, so to say, which suggests that the severity is much more. So in the next slide, we'll see what exactly is Cullen's and Gray Turner sign. So basically, as you know that the pancreas is located in the retroperitoneum. So whenever there is peripancreatic hemorrhage happening, this hemorrhagic fluid travels along the retroperitoneum and along the various folds. It comes into the anterior abdomen. That means from the retroperitoneum it travels, and between the various layers of the abdominal wall it comes, and the whole of the abdomen may have patchy areas of hemorrhagic spots. Okay, and the same thing happens in the region of the umbilicus. I have pictures in my next slide where it is quite apparent. Yes. So this is the Cullen. The Cullen sign is when you have this peripancreatic fluid basically travels anteriorly, comes to the region of the anterior abdominal wall, and there along the ligament of Achilles, it basically leads to collection of this fluid, especially around the umbilicus. And this sign is also seen sometimes in a case of other cases, like I think ruptured ectopic is another area where it was typically described. In fact, it was first described in the case of ruptured ectopic. Okay, but Cullen sign is something that you see this kind of hemorrhagic patch around the umbilicus. And the Gray Turner sign is where you see the same picture happening in the flanks. So the common complications of acute pancreatitis are the following. Number one, there is acute fluid collection, and this fluid collection is usually around the pancreas, which is called as peripancreatic fluid collection. And if the collection is large, then we just label it as something like acute fluid collection. And at some point in time, this fluid collection which has happened tends to kind of get walled off, and when it starts getting walled off, we call it as a pseudocyst. Any pseudocyst or any localized collection of fluid which is less than 4 weeks old, 4 weeks since the time of onset of pancreatitis, those type of pseudocysts are called as acute pseudocysts. Once they are more than 4 weeks old, they are called as mature or chronic pseudocysts. Then you also have this pancreatic fluid collection that has happened, that if it gets infected for whatever reason, then you end up getting what is called as a pancreatic abscess. So this pancreatic abscess is generally an abscess which happens as a result of infection of the acute fluid collection which has happened. because of the inflammatory process, and usually it is around the pancreas, peripancreatic. Then because there is so much of inflammation happening, and also because of the SIRS-like phenomenon which is there and multisystemic involvement, very commonly what we see is a patient also has pleural effusion, and that pleural effusion usually is having high amylase and lipase. So you have pleural effusion which is rich in serum amylase and lipase. So that is basically what you call as pancreatic pleural effusion. Then you also, of course, the acute fluid collection, if it is there around the pancreas, that is called as peripancreatic fluid collection. When the same thing is there all over the abdomen, then it is called as a pancreatic ascites. How it is different from other types of ascites is, apart from the fact that there was pain at the onset and other things, if you aspirate the fluid and send it for serum amylase and lipase, the serum amylase and lipase will be very, very high here. Okay, so that's what is different from the regular ascites which you get. Now the third thing, the last thing is something called as pseudoaneurysm. Now, as you know, there are a lot of enzymes which are elaborated, like especially elastase. So elastase, what happens is usually acts on the blood vessels and leads to weakening and formation of pseudoaneurysms. And these pseudoaneurysms, when they rupture, they can lead to torrential bleeding and the patient can die because of it. So these are the basic complications that happen. And then we have what we classically label as systemic complications. So we will just look system-wise what are the problems we can have. So in the pulmonary system, you can have atelectasis. Atelectasis, I hope you know what is atelectasis. Atelectasis, what exactly happens is one of the smaller airway gets blocked either because of infection or surrounding area consolidation, and because of the block, what is happening is there's no air that goes into that segment of the lung. So that lung basically collapses, and that entity is basically called as atelectasis. So you can have atelectasis happening, you can have pleural effusion, and of course the worst case scenario would be pleural effusion is basically collection of fluid in the pleural space. Now, ARDS also you have fluid collection. When in ARDS, the classical fluid collection is not exactly in the pleural space, but it is basically in the intercellular space, the interstitial space, the collection happens. Okay, so ARDS is quite a life-threatening situation, and once the patient goes into ARDS, many times the patient may require mechanical ventilation. And in the present ongoing viral, COVID that is there, and that also ARDS is one of the key points that sets in at some point, and that leads to basically prolonged ventilation. And of course, there is poor air exchange and other things that happens. Then if you look at the cardiovascular causes, in cardiovascular, the effect, in the cardiovascular system, one of the important things that we see is something that is called as a cardiogenic shock. Apparently, the cardiogenic shock happens because of some sort of a myocardial depressant factor that is released from the pancreas. What exactly it is, we do not know, but it is labeled as myocardial depressant factor, and that is the one that is responsible for cardiogenic shock. When we say cardiogenic shock, that basically means the cause of the shock is the ability or the inability of the cardiac pump to do its function normally. That means because the myocardium which gets depressed, the heart is not able to maintain the cardiac output and the stroke volume. And that is the reason why the BP drops. You can also have some neurological changes. Basically, it's encephalopathy, but the encephalopathy happens mainly because it's a metabolic derangement that leads to encephalopathy, and the cause is because of pancreatitis, so it is labeled as pancreatic encephalopathy. Then in the metabolic causes, there are quite a few things that happen. Number one is there is metabolic acidosis. Now, the reason why metabolic acidosis happens is the moment there is shock, the first thing that you will see is there is local acidosis happening. But when there is shock-like state all over the body, what happens is that contributes to systemic metabolic acidosis. The second thing that happens is hypocalcemia. Now, what happens is these enzymes which come out of the pancreas, they lead to what is called as saponification of the fat. saponification of the fat usually around the peripancreatic, and that is how basically the necrosis of pancreas happens because of saponification of fatty tissues. So when saponification is happening, what also happens is the calcium gets deposited. Okay, so it's something like forming soap. Along with fatty acids, you have some metal that is combining. So that whole process is called saponification. So because calcium takes part in this saponification along with the enzymes that are released and the fatty acid from the fats, there is a drop in the calcium level. So there is hypocalcemia. So this is something that is very important. And altered glucose metabolism is something that is a natural phenomenon that happens in all cases where you have severe stress. So in this case, there is not only there is severe stress because of the surge that is happening. What is also happening is the patient, this is where insulin and glucagon get secreted. So what happens is usually if there's less amount of insulin coming, that means there's not enough insulin available to move the glucose from the plasma area to the intracellular area for its metabolism. So that can lead to hyperglycemia. So typically what you see is there hyperglycemia. Okay. Then hematological, it can lead to, because there's a lot of GI bleeding that happens because of formation of pseudoaneurysms and other things. That severe bleeding can lead to DIC. And because there is a shock-like state which is prevailing, patient can go into pre-renal failure. So if you look at what are the differential diagnosis, I think we have briefly discussed the differential diagnosis in terms of pain. Okay, so it could be cholecystitis, it could be cholangitis. Cholangitis because sometimes, especially in acute gallstone-induced pancreatitis, patient is also jaundiced. And many a times in cholangitis also you will have a jaundiced patient having fever. So here, of course, in cholangitis, the fever component is a little more typical. And in a typical cholangitis, the pain is usually in the right hypochondrium. But many a times, there can be confusion between cholecystitis and cholangitis, and they can sometimes mimic acute pancreatitis. Other conditions are something called as chronic mesenteric ischemia. When you say chronic mesenteric ischemia, it usually means ischemia which is usually confined to the superior mesenteric artery or the inferior mesenteric artery. Celiac axis is usually not involved, but most commonly mesenteric ischemia involves the superior mesenteric artery. And if the ischemia is kind of prolonged, then you can lead to what is called as a mesenteric infarction. I have already told about the chronic duodenal ulcer, especially the chronic duodenal ulcer which is located posteriorly, that can mimic. And of course, when it can perforate, or any other sort of perforation you have, you can have the condition mimicking acute pancreatitis. Sometimes bowel obstruction also can mimic pancreatitis. Myocardial infarction I have talked about, pleuritis, and of course pneumonia itself. These things can be close differential diagnosis for this. Like I mentioned earlier, or in the earlier slides, the chronic, the acute pancreatitis can mimic most of the acute abdominals, but these are the common conditions which need to be ruled out. And typically what happens is, irrespective of whether we are thinking it is cholecystitis, or it may be cholangitis, or mesenteric ischemia, or mesenteric infarction, or a chronic duodenal ulcer, or a bowel perforation, or obstruction, myocardial infarction, pneumonia, pleuritis. Once we do the enzyme levels and we find that the enzyme levels are raised 3 times, we get a diagnosis, and we know that this is basically nothing but a case of acute pancreatitis. So now, whenever we are faced up with a patient who presents like this, you need to obviously establish a diagnosis. So before you establish a diagnosis, generally based on the history and the clinical findings, you are expected to be able to have some sort of a working diagnosis. Now, typically, if the patient is a known case of gallstone disease, and he has had similar pain in the past, most likely it might turn out to be a case of gallstone-induced pancreatitis. Again, if the patient is a known alcoholic and off and on he has had similar pain abdomen, it is quite likely that this may be acute pancreatitis, and the cause perhaps is because of alcohol. So these are the two leading causes. And if you have usually a child or a younger age who's neither alcoholic nor having gallstones coming with sudden pain abdomen and vomiting, it is quite likely in our Indian scenario it could be because of worm-induced pancreatitis. And of course, in places like Kerala, you have typical things like I talked about, this cassava or the yam, which can lead to pancreatitis. Then in familial history, if you have similar problems, it could be a case of familial pancreatitis. So now, when you want to establish a diagnosis, there are two things that you need to keep in mind. Number one is what type of pain he's having. If the pain is very typical, it is sudden onset of severe pain in the epigastrium, which is radiating to the back, and the patient feels comfortable when he sits in the bed and bends forward, then we can say quite safely that it may be pancreatitis. But then there are two other pains that needs to be kept in mind as chronic duodenal ulcer and perforated duodenal ulcer. Now, perforated peptic ulcer, the history is quite different, and the involvement is a little more generalized. But of course, in pancreatitis, the same can be. So clinically, many a times it is very difficult to rule out. The moment you do the enzymes, you know what exactly is the diagnosis. So if you look at the enzymes, we go by the rule that either the serum amylase or the lipase, from the basic or the basal level, it should have at least a threefold increase in the values. Okay, so once you have amylase or lipase or both, which is more than 3 times the normal value, then along with the pain abdomen, we can conclude that yes, probably this is a case of case of acute pancreatitis. Now, many a times what happens is, in a case of chronic pancreatitis, the levels may be high, but they may not reach threefold, because what is happening is in a chronic pancreatitis, because of repeated inflammation, the pancreas has lost its exocrine function or ability to secrete so much amylase and lipase. Therefore, the level may not reach threefold high. Okay. Whereas in acute pancreatitis, we do insist that the level should be threefold rise. But many a times in a clinical practice, we find that the levels are not really threefold increase, and yet without threefold increase, we do end up making a diagnosis of acute pancreatitis, and most of the times we are not wrong. Now, other thing you need to do is the blood counts. When you do blood counts, the hemoglobin, usually the hemoglobin gets reduced in the case of necrotizing pancreatitis. If it is simple edematous pancreatitis, usually the hemoglobin levels, there is no reason why the hemoglobin level should fall. Whereas in necrotizing pancreatitis, where there is so much of hemorrhage that is happening, in that case, what happens is the hemoglobin level falls down. And once the patient has pseudoaneurysm, and because of pseudoaneurysm, if he's having bleeding from the GIT, the hemoglobin levels will fall further. Now, as far as total count and especially neutrophils are concerned, the total count in SIRS usually goes up, and if there is some superadded infection which has set in, then the neutrophil count continues to go up, and probably from SIRS the patient has progressed into sepsis. So basically, in the setting of SIRS, if you have infection, that is what is called as sepsis. And as far as blood sugar levels, we have already discussed that there is stress-induced increase, so the patient has high sugar levels. Blood urea is likely to go up because of hypovolemia and shock state that the patient is. And once the renal perfusion is reduced, the patient can have serum creatinine levels also going up. Initially, urea goes up, and later on, if it's not corrected, the serum creatinine goes up. As far as serum calcium is concerned, I have already explained to you how saponification of fat happens in the peripancreatic area, and that is the reason why the calcium levels drop. Now, if you are to do the LFT, like I told you, gallstone-induced pancreatitis usually will have accompanying jaundice, but sometimes the jaundice is so mild that many a times you may, especially when you're examining the patient in the night, when natural light is not available to you, many a times you may miss the fact that the patient is electric. However, when you do the LFT, in such patients, you will find the bilirubin total and direct both will be raised, and that is what helps you clinch the diagnosis of gallstone-induced pancreatitis. Now, ALT, AST, alkaline phosphatase. Now, ALT and AST, these are basically substances or enzymes which are elaborated from the hepatocytes. Okay, so once these two levels go up, that usually means there is hepatocellular damage that is happening. And in pancreatitis, the only way in which hepatocellular damage can happen is when the patient has gone into what we call as multi-organ dysfunction syndrome. So, increase of ALT and AST is not a good thing that we see in acute pancreatitis. In fact, it is a harbinger of a poor prognosis. Now, when the total and direct is raised, usually what happens is in gallstone-induced pancreatitis, the stone which is obstructing also leads to increase of the the stone which is obstructing has led to increase in the bilirubin, total and direct, and also alkaline phosphatase, which is basically secreted from the biliary duct epithelium. That level also goes up. Okay. Now, as far as proteins are concerned, usually if it's an alcoholic, be rest assured that the protein component, protein component actually will be a little less. And as PT is prothrombin is important in those patients who come with gallstone-induced pancreatitis, because if it is severe gallstone-induced pancreatitis, in the setting where the patient is going into multi-system problems, patient there is a possibility that the patient can bleed because of necrotizing variety of pancreatitis. Now, if that happens and if this PT is deranged, then the patient will keep bleeding and end up with coagulopathy. So, especially in those patients who have gallstone-induced pancreatitis, monitoring very closely the prothrombin levels is very, very important. LDH, of course, we do measure LDH. LDH comes out from a lot of various parts in the body, like it can be from the liver, it can be from the muscles, it can be from the heart. So the total LDH level actually is a very good indicator of tissue damage. So usually in severe pancreatitis, the LDH level goes up. Amylase, I have already talked about, but we need to talk a little bit more about amylase, because amylase is something where you can expect short notes and also MCQs. So basically, a threefold increase in amylase is usually suggestive of pancreatitis in the setting where the patient is also having a typical acute pancreatitis like pain abdomen. Only increase in amylase is not what gives you the diagnosis, because there are few other spurious conditions where the amylase level may go up and the cause is not exactly pancreatitis. I think you can take it as a homework and try and find out what are the areas where something called as microamylasemia happens. Okay, and that is not because of pancreatitis. Yeah, so the increase usually in the setting of pancreatitis happens within 1 to 12 hours of the onset of symptoms. That is very important. Serum amylase basically starts increasing by 1 to 12 hours of the onset of symptoms. And once the levels reach high, 2 hours or 12 hours, it has gone up and is detectable. Usually, it stays for anywhere between 3 days to 6 days. So the levels, once they increase, they stay increased for about 3 to 6 days. And after 3 to 6 days, the levels start coming down. So patients, so if you have any person whom you have detected the amylase to be high, let's say at 12 hours, and you expect that latest by 6 days the level should have fallen, but on the 10th day also you find the levels are still raised. Okay, that usually means that the patient is not doing very well. That means the inflammatory process in the pancreas is still persistent. There's still an ongoing inflammation. And also it may suggest to you that the patient is going into a lot of other complications. So amylase has both a diagnostic value, diagnostic in the sense within 2 to 12 hours, if the values are threefold more than the normal values, you can make a diagnosis of pancreatitis. The levels usually fall down by 3 to 6 days, but if you find that well after 6 days, the levels instead of going down have remained static or are going up, especially if it is going up, that usually means that prognosis is bad. Bad because there is still a ongoing inflammation and perhaps the patient has also developed a lot of other complications because usually after the first week, the various complications of pancreatitis that we see usually start setting in after 1 week. And of course, okay, I think I have given you the answer here already. So basically, hyperamylasemia can be seen in many other conditions. But when I say hyperamylasemia, it is not the threefold increase. And that is the reason why very safely we ask for a threefold increase in amylase level to be able to diagnose acute pancreatitis. Because you can have this amylase level going up in acute cholecystitis, perforated hollow viscous, and sometimes even in just bowel obstruction and bowel infarction. Okay, and of course there are some familial reasons for hyperamylasemia to happen. So if you go purely by increased amylase level, you may not end up with a diagnosis of pancreatitis. So it is not only hyperamylasemia that we see, it is the threefold increase that we look for. And along with that, usually accompanying typical pain abdomen or at least pain abdomen should be there. Other this you need not bother, but maybe as a PG sometimes we talk about urine amylase. Basically, what happens is once the amylase level goes up, see in the serum it takes about 3 to 6 days to normalize. Okay, but what happens is these patients in the urine, if you test for amylase, well after the levels in the blood have normalized, you can find traces of it in the urine. That's what it means. Now, serum lipase. So on one aspect, you have serum amylase and serum lipase. Somehow we talk more about serum amylase, but less about serum lipase. So let's see how is serum lipase different from serum amylase. As compared to serum amylase, that increased by 2 to 12 hours. This increases within 4 to 8 hours of symptoms. So apparently, the range there is much more. It could from 2 hours to 12 hours. This is from 4 to 8 hours, and that one peaked by usually by 12 hours it peaks, but this takes a little longer time to peak. Okay, and that normalizes in 3 to 6 days. Then this is normalizing somewhere between 8 to 14 days. So many a times what happens is sometimes when the patient comes a little late to you in the hospital, you do the test and you find that the serum amylase is normal. Okay, but in the second week usually, second week where the serum amylase should have normalized, supposing the patient has come somewhere in the second week and you do the amylase level, you find the amylase levels to be normal. So technically you may miss the diagnosis of pancreatitis if you don't do serum lipase level. But if you do serum lipase level within the second week, that means after 8th day to 14th day, it is quite likely that you will find the lipase levels to be high. Okay, so serum amylase is detected a little early, whereas serum amylase is there in the system for a little longer time, and therefore it can be detected well after 1 week. That's the message here. Elevated lipase levels persist. So this is something that I have already told you. This levels can persist and be high even after the amylase activity has returned to normal. So usually it is useful in patients who appear a little late to the hospital. Now, when we talk about imaging modalities, the first thing I want to convey to you that imaging of the pancreas to demonstrate that yes, edema is there or pancreas appears enlarged or peripancreatic inflammation is there. Most of the times you do not need an imaging to give you a diagnosis of pancreatitis. There are some who say that it's a combination of clinical signs, the serum levels of amylase and lipase, and imaging that gives you a diagnosis. But most of the recent data would suggest that to give a diagnosis of acute pancreatitis, you just need the typical pain abdomen, and that combined with threefold increase in amylase or lipase. That is enough to give you a diagnosis. So the question is, why do you need to do imaging? The reason why we do imaging is many a times you don't typically get the threefold increase in amylase and lipase. Pain abdomen is quite suggestive of pancreatitis, but the levels of amylase and lipase that you've got are not typically threefold increase. And your diagnosis is kind of doubtful. You're not sure whether it is this or that. And you don't want to miss out on something else. So that is the reason why many times you do imaging. Otherwise, if you want to image the pancreas, we also know that the pancreatic complications like necrosis and other things, usually after 1 week only those changes are apparent on a CT scan. So the best time to do a CT scan in the case of acute pancreatitis is usually after 1 week. If you have to do it earlier than that, that is only to make sure that you don't miss some other diagnosis. So whenever your diagnosis is in doubt, you're not sure whether it is acute pancreatitis, maybe in that setting you're justified in doing a CT scan. So the best imaging modality for detection of acute pancreatitis changes in the pancreas is, the best investigation is a CE-CT scan. However, the most often done investigation is usually ultrasound. So let's say what all in the imaging, what all we have. Okay, so if you do a plain X-ray abdomen, usually what happens is sometimes you can see gallstones. So you know, okay, probably it's gallstone related pancreatitis. But again, the gallstones are so common that sometimes gallstones may be there. But the reason why the patient has pancreatitis not because of gallstones, but perhaps because he's also alcoholic. Okay, so you can detect gallstones, and sometimes in acute pancreatitis, what happens is there is something called as see, I told you bowel obstruction can be one of the differential diagnoses here, because in acute pancreatitis it has a very typical picture. Not every case, but in some case where it mimics, something like bowel obstruction, and that is basically on X-ray. We call it as the colon cutoff sign. Colon cutoff sign in the region of the pancreas. What happens? The transverse colon abruptly, there is gas collection proximal to, and distally there is nothing, and that is what is called as colon cutoff sign. So that colon cutoff sign is sometimes what you see. And this apart, of course, so in the plain X-ray abdomen, this is what you see. In a chest X-ray, you can see pleural effusion, and probably you can also rule out the fact that there's no consolidation, there's no pneumonia, so there's no chance of this one being, so there's no chest condition which is causing this pain. Therefore, you probably end up saying that yes, it is because of pancreatitis only. Okay. And of course, because of pancreatitis, more often than not, patient will have pleural effusion. And sometimes, like I said, ARDS picture also you may see in the chest X-ray, and sometimes some areas of atelectasis which appears as collapsed area. All these things you can see in a chest X-ray. So chest X-ray is usually a PAB. One of the most frequently done investigation, because of the ease with which it is available and doesn't require much expertise and is not very costly, is ultrasound abdomen. So ultrasound abdomen will be able to rule out polylithiasis, biliary sludge, bile duct dilatation, pancreatic edema, and pseudosis. These are the various pictures that it can show you. So pancreatic edema can be there in early pancreatitis. In a severe variety, of course, you can have what you call as the necrotizing variety will have a lot of peripancreatic fluid and acute pseudosis and all that. So basically, ultrasound is not really required to establish a diagnosis, but more often than not, we always end up doing ultrasound of the pancreas in acute pancreatitis. And mostly, when you do, you will find that there is some degree of the pancreas, the head area usually appears enlarged because of pancreatic edema. And if there is peripancreatic fluid, that fluid also may be seen. If there is any pseudocyst or acute fluid collection in that area, you can see acute pseudocyst or acute fluid collection happening. Of course, the gold standard is a CT scan. Contrast enhanced CT scan, like I said, is not really required to establish a diagnosis, but when you want to see how severe the pancreatitis is, especially in those patients who are having a hemorrhagic variety. In hemorrhagic variety, again in a hemorrhagic variety, if you do the CT scan too early, before 1 week if you do it, you may not get much information as to how much of necrosis of the pancreas has happened. So the best timing is when you do a CT scan is usually somewhere around after 1 week. That is when you get the best information as to how much of pancreas has undergone necrosis. So CECT, like I have already stressed upon, is the gold standard for diagnosis of pancreatic necrosis and peripancreatic fluid collection, and also for there is a sort of a formula or prognostic indicator which is known as Balthazar's criteria. You need not remember it. If you can remember the name, very good. But as far as you being undergraduates, you don't really have to know about Balthazar criteria. So in Balthazar criteria, what happens is we measure the degree of necrosis that has happened on a CECT scan, and based on that, if it is less than 30% of the pancreas necrosed or between 30 to so much, we call it, grade 1, grade 2, grade 3, it goes like that. So we grade it based on the amount of necrosis that has happened. Now, so CECT basically, as we have said, it is contrast enhanced. So basically, contrast is also given, and the contrast is given as IV contrast. Okay. So basically, it's combined with the bolus administration IV contrast material, and helical CT or spiral CT is taken, and by doing that, we are able to detect a lot of changes, especially pancreatic swelling in the case of early disease. If you happen to do, like I said, the early disease is not really required, but more often than not, when we actually do it in a setting where the patient is having necrotizing pancreatitis, like I said, the best timing to do it is usually after 1 week. By then, usually what happens is the pancreatic area which is undergoing necrosis has undergone full established necrosis, and there's no blood flow into that area. So the IV contrast that we have given, now there are patchy areas where in the pancreas there is no contrast being taken up, and that is the area where we say is necrosis. So CECT can also be used to detect and follow up pseudosis and to permit fine needle aspiration of areas suspected to be harboring any infection in the pancreas. So one of the important thing in the prognosis of the patient is, once peripancreatic fluid collection happens, anyway as a part of inflammation, it is expected. Over a period of time, these things get localized and they form acute pseudosis, and after some time they completely disappear. When they continue to be there, they are called as chronic pseudosis when they are there more than 4 weeks. Now, one of the worst things that can happen to a patient of pancreatitis is this pancreatic secretion or the pancreatic fluid that is there all over the abdomen, including in the chest, if it gets infected. Okay, so knowing whether or not infection has happened is of paramount importance. And many a times what happens is, if the patient is not manifesting outright signs of infection, but we strongly suspect that the patient is having ongoing infection, sometimes a fine needle aspiration of the pancreatic fluid is done and sent for culture sensitivity so that we can detect the infection and treat it early. So, like I have already told you, there is CECT scan has no use in the early phase, where clinical features and race enzymes are enough to give you a diagnosis. It is usually useful after 1 week when complications set in. And also the other reason why we use it is to rule out other possible diagnoses. MRI. Now, we have talked so much about CT scan. So it obviously means one thing, that MRI is not really necessary for you to either diagnose or to prognosticate pancreatitis. The Balthazar criteria that I talked about is based on CT scan. Okay, so Balthazar criteria gives you a prognostic indicator about which patient is likely to do well, which patient is likely to do poorly, and which patient is somewhere in between. So technically, MRI is not really required as far as management of pancreatitis is concerned, but there are some areas where, in certain complications, perhaps MRI and MR angiography may be required. So as far as MRI is concerned, it doesn't exist as far as pancreatitis is concerned. In acute pancreatitis, the most important and the gold standard investigation is CECT scan. But the timing is important. It is not done usually within the first 1 week. If you do it within the first 1 week, it is usually to rule out other possible diagnoses. In a severe pancreatitis, usually we do it after 1 week, and that is the time when necrosis is very, very evident, and based on the necrosis, we are able to prognosticate the patient. Now, pancreatitis is one area where there are a lot of, I have talked so much about the, CT scan which can prognosticate. I have talked about some of the clinical features which suggest that there is hemorrhage going on, like the Cullen sign and the Gray Turner sign. Then I did talk about the drop of the hemoglobin, okay, which means there is ongoing hemorrhagic pancreatitis. Then I did talk about LDH levels going up. I talked about ALT and AST going up, which is usually suggestive of some degree of multiple organ dysfunction syndrome. So now, based on all these things, there are a lot of criteria which are available to you. So before I discuss with you what are the criteria, I just wanted, probably this I'll be discussing in the next class, but the ones which you need to know is number one, Ranson's criteria. IMRI criteria, just if you know the name, that is fine enough. This Apache. Apache scores are not very important. Apache, there's something called Apache 1 and 2, but this is a very extensive scoring system, and at your level, definitely we don't expect you to know it. But if you just know Apache and what Apache stands for, that is fine, good enough. There is one more thing called a simplified acute physiology score, which is a simplified version of Apache, which is called as SAPS-2. That is sometimes used, but I think I will want you to remember Ranson's criteria, and please also remember something called as BISAP or BISAP. BISAP stands for Bedside Index for Severity in Acute Pancreatitis. Believe me, it's a very simple and straightforward one. And Balthazar, I think you need to understand what Balthazar is. You may not try to mark it up and remember. Sometimes the MCQs you may get, all of these will be put together and you will be asked which is the most commonly used. So the most commonly used indicator or prognostic indicator is usually Ranson's. Which is the best? Perhaps for severe degree of pancreatitis, Balthazar criteria gives you the best